Welcome to the Clinical Rounds podcast. I'm Dr. Khan, and today we are diving into one of the most practical cheat codes in medicine, the Dermatome Map. Joining me is Dr. Sarah, our resident board exam guru.
Glad to be here, Dr. Khan. While students often see the Dermatome Map as just a colorful, confusing diagram to memorize, it is actually a high-yield gold mine for the USMLE. If you know the map, you can localize a spinal cord lesion without even ordering an MRI.
Exactly. I like to think of it as the body's internal GPS system. Each segment of the spinal cord is like a main power station, and the dermatomes are the specific zip codes or neighborhoods those stations provide electricity to. If the power goes out in zip code T10, you know exactly which station is broken.
To keep our definitions precise for the boards, a dermatome is the area of skin supplied by the somatic sensory fibers of a single spinal nerve. It's important to distinguish this from the territory of a peripheral nerve, which often carries fibers from multiple spinal levels through a plexus.
That is a crucial distinction. Why does this matter clinically? Well, imagine a 65-year-old man comes into the ER, much like the case in our textbook. He has crushing chest pain, but he's also complaining of pain radiating down his left arm and up into his jaw. Now, his arm isn't being crushed, so why does it hurt?
That's referred pain, and it's dermatomal logic at work. The sensory fibers from the heart enter the spinal cord at the same levels as the skin of the chest and the medial arm, specifically T1 through T4. The brain gets crosstalk and perceives the cardiac distress as skin pain in those specific dermatomes.
It's like a crossed wire in a switchboard. Now, when we look at the map itself, the trunk is pretty straightforward. It looks like a stack of horizontal bands, but the limbs are a bit of a mess. Sarah, how should students visualize the arms and legs?
The limbs are trickier because of embryonic rotation. When we were tiny embryos, our limbs grew out like paddles, and as they rotated, the dermatomes got stretched and twisted. On the boards, they love to test the landmark dermatomes. You don't need to know every inch, but you must know the big five.
Give them to us. What are the high-yield landmarks?
Okay, number 1, C6. Think of the 6 shape you can make with your thumb and index finger. C6 covers the thumb. Number 2, T4. T4 is at the teat or nipple line. Number 3, T10. T10 is at the belly button or umbilicus. Number 4, L4. L4 hits the down to the floor. It covers the medial malleolus of the ankle. And number 5, S1. That's the lateral side of the foot and the little toe. That T10 at the belly button trick has saved many students. But here's a clinical curveball. If I take a scalpel and purely cut the T10 spinal nerve, will the patient have a perfectly numb circle around their belly button? Actually, no, and this is a very common board question. On the trunk, adjacent dermatomes overlap significantly. The text notes that you usually need to lose 3 contiguous spinal nerves to produce total anesthesia in one spot. It's a biological redundancy system.
Right. It's like shingles, the herpes zoster virus. It lives in the dorsal root ganglion and travels down the nerve. You'll see that classic belt of painful blisters. It follows one dermatome, but the patient often still has some sensation there because the nerves above and below are covering for the damaged one.
Since we're talking about diagnosis, we have to mention how this pairs with myotomes, the segmental innervation of muscles. If a patient has a herniated disc, a neurologist, who would be the doctor of choice for this evaluation, won't just check for numbness, they'll check the reflexes.
Why does this matter clinically? Because if a patient has a compressed L4 nerve root, they'll have sensory loss on their inner leg, and their patellar reflex, the knee jerk, will be diminished. The map and the reflexes together give you a 3D picture of the spinal cord.
Exactly. Just remember the reflex levels. C5, C6 for biceps, L2, L4 for the knee, and S1, S2 for the ankle. If you see a patient who can't feel their pinky toe and has a weak ankle jerk, you're looking right at an S1 issue. It's elegant, really. We're using the skin as a window into the central nervous system. Before we wrap up, Sarah, any last-minute board tips on this topic? Yes. Remember that the posterior rami of the spinal nerves handle the skin of the back, while the larger anterior rami handle the front and the limbs. Also, keep an eye out for saddle anesthesia, loss of sensation in the S3 to S5 dermatomes. That's a medical emergency called cauda equina syndrome.
Great point. If they can't feel the area that would touch a saddle, get them to surgery fast. All right, let's summarize the key takeaways. First, a dermatome is a skin map of single spinal nerve levels. Second, know your landmarks. C6 is thumb, T4 is nipple, T10 is umbilicus, and L4 is medial ankle. Third, overlap is real. It takes 3 levels of injury to cause total numbness on the trunk.
And finally, use the Dermatome Map to localize referred pain and nerve root compressions. It's the most powerful physical exam tool you have.
Thanks for joining us. Now go out there and start mapping your patients. We'll see you next time.